afternoon, everyone. Welcome back to this session. My name is Araminta Johnson. I am the Marketing Manager and Content Developer at iCAAD. And it gives me great pleasure to extend a very warm welcome to Dr. Pippa Hugo, who is coming from the Schön Clinic. She is a consultant adolescent psychiatrist who strongly believes in the importance of engaging young people and encouraging their voice while supporting parents to develop the understanding and skills required to help their children. And she will be presenting this session on, obviously, child eating disorders. Well, I'll hand it over to Pippa now. Thank you very much.
Thank you. Oh, how do I get this? There we are. Good. Thanks very much. I just want to get an idea if people are happy to do a little bit of participation. Yeah, rather than listening to me drone on for the next hour or so. Good. As was mentioned, I'm an adolescent psychiatrist and I work primarily in eating disorders at the Schön Clinic, where we have an outpatient and we'll be having a day patient service. And what I'm going to be talking about today is just kind of remind us of what is anorexia and talk a little bit about an overview of our understanding of the etiology of anorexia nervosa. Have a think about what effect actually starvation has on people. I'll wait for some people coming in here. And then I'm going to spend most of my time talking about family treatment models that we use in the treatment of adolescents with anorexia nervosa, and a little bit of time on thinking about factors that are associated with recovery. Can I just get an idea of how many people here actually work with adolescents or work with people with eating disorders? So I might be actually telling you things you know already. Yep. So just let's remind ourselves. Anorexia nervosa is a very serious psychiatric illness with high rates of comorbidity. And as we know, up to about 50% of people with anorexia nervosa meet the criteria for other disorders, for example, depressive illness, anxiety disorders. And these young people have a significantly impaired quality of life. And it is an illness that has the highest mortality of any psychiatric illness. And I think that sometimes gets forgotten about. These disorders develop during adolescence, and as we know, primarily, but not exclusively, amongst girls. And anorexia nervosa has a significant developmental and medical and psychological consequences. So they are very significant illnesses, and these are not just young people who are going on a diet. And the symptoms, as we know, are of low body weight, although in younger people, sometimes the symptoms are really more about growth stunting rather than actually the body weight being low. So I'm just thinking about a young person that we've been involved with recently who has not grown for about 4 years. So she's 16 and she's about this tall. But she doesn't look as though she's very underweight. So her illness began when she was about 11, and she hasn't really essentially grown since that age. So one can be fooled, really, in youngsters that this may not be anorexia when it actually is. Typically, these people have a fear of weight gain, but again, I find in the younger population, they don't always do that. I've had a lot of young people almost confused about what's happening to them. They find that they've developed a problem where they just don't want to eat. But it didn't start with wanting to lose weight. Often it started with perhaps feeling full or just losing their appetite. And then they become quite terrified, really, of the fact that they've got this thing in their mind that's telling them not to eat, unrelated to weight, and it feels kind of out of control. So again, that's slightly different in young people with anorexia. And what we often find is, I think when you help get their weight up, that then sometimes, perhaps as they get older, the fear of weight gain then emerges, but it's not always there at the beginning. A lot of these patients have behavior that interfere with weight gain, so they clearly might not be eating enough. They may be exercising excessively. They may be purging. And again, with younger people, I find that they don't really engage in much laxative use or other kind of more extraordinary methods of getting rid of weight. Generally, it's dietary restriction, excessive exercise, and then possibly purging kind of comes along at one point. And we do know that a lot of teenagers actually experiment with all of these things, really. So I think there's a whole group of young people that we see that that diet sometimes to excess, that do engage in some purging behavior, that occasionally exercise to excess, but they don't actually reach the criteria for anorexia nervosa. And I see quite a lot of these patients now, more renowned patients, that certainly in this country, in the NHS, they might not reach the criteria for being referred to the NHS outpatient services, but they are quite troubled, actually, about their weight and shape and have these some significant behaviors. These patients are disturbed in the way their body image is perceived, so frequently feel that they are fat when other people can see quite clearly that they're not. But not exclusively again. And I do think there's something about the evolution of this illness, that early on in the illness, perhaps some of them I find that they can actually see that they're underweight, but they can't do anything about it. The weight and shape becomes extraordinarily important in their evaluation of themselves. So they get on the scale, their weight's gone down, they have a good day, they get on the scale, their weight's gone up, 0.1, 0.2, they have a terrible day. And I think one of the things that's quite unique to this illness is that most young people and adults who suffer from this lack the kind of insight into the seriousness of the illness. And for many of them, the term egosyntonic is used. So for many of them, they are quite comfortable with the fact that they're not eating, they're losing weight, and in fact, it's making them feel really good. And many of them are in complete denial that there's a problem, and the problem they see is in others. And for many of them, they actually feel that having lost some weight and not eating too much has helped them achieve and excel in other areas of their life. So it's kind of got a lot of bonuses to it. And as I've mentioned, the presentation might be different in younger people, particularly those that are prepubertal. It was interesting. Anorexia has been around for a very long time, and I was literally going through my posts and flicking through my journals this week, and I came across this in the British Journal of Psychiatry in March this year. And these are papers that were from the Royal Society, and this was from 1705. So this was, to my mind, one of the first descriptions I've ever read. And this physician had written about two women, one of whom had died and the other had lived. And the woman by how would you pronounce that, George? Llangollen, was written, she lived 10 weeks and some odd days without sustenance. She had lived so before for a fortnight and always in a trance. It may be, for aught I know, a disorder of nature in her. It reminded me of sitting in mental health act tribunals where we had to say if something is a disorder of nature. As we sometimes find it in excess of appetite, and both very unaccountable. For the woman of Llangollen's character, I find it agreed upon in general that she was grave, sober, and religious, but not without a deep tincture of melancholy, being from her childhood subject to disquieting thoughts and frightful dreams. She was constantly at the service of the church. From much attention to dark thoughts, she came at last to believe that something spoke to her and gave advice and comfort against severe temptation and trials from her spiritual enemy. And I was kind of wondering what the temptation was and whether the temptation itself was food. And then there was something written about the Derbyshire woman, who is said to have lived 16 months without meat or drink and afterwards recovered her health. So interesting descriptions. But how do we think about anorexia nervosa today, and what kind of leads to the development of this illness? So this is a kind of useful template I use to think about this illness from the book by Professor Lask and Rachel Bryant War. And as you can see, we start with genes, which determine our temperament and personality, and we know that a lot of young people who develop anorexia have a more anxious temperament. In fact, there are high rates of anxiety disorder before the development and afterwards the development of the illness. We're subject to sociocultural factors that we all know only too well about. These convey a certain vulnerability, and then at a critical time of life, in association with other stresses, and the stresses, importantly, may not be to other people very huge stresses. There may be friends didn't really talk to you very much that week. So for another child with a different temperament and a different vulnerability, it may not have had the same results. And there may, in fact, be factors in the family coming into play here. And all of these things together work together to develop an eating disorder. And this is another diagram from his book, which indicates what happens when that child is vulnerable. How does that kind of develop in the child's thinking to develop an eating disorder? So you have a young person who has those vulnerabilities we've talked about, subject to particular stresses, experiences a sense of failure, low self-esteem, a sense of loss of control, a feeling of needing to gain control in some way, begins to diet, although, as I mentioned, they may not think about it as a diet, they may not eat very much. Through this, they develop a sense of achievement. This makes them diet more, and an eating disorder ensues. So that's two ways of looking at it. And throughout this talk, I'm going to be thinking about a patient I have. Let's call her Izzie. And Izzie is 13 and she's nearly 14. And she came from a middle-class background. Her father particularly worked quite long hours away from home. Her mother had a history of depression. And she had an older brother who gave her quite a hard time in her childhood, and a younger sister. And when she was coming up to secondary school, the family decided that she initially went to one school, which didn't really work out, and then they decided she should go to boarding school. And that was partly because her mother wasn't very well with her depression, and partly it was the kind of family tradition that people went to boarding school. And this was a real challenge for her, and she became deeply homesick. And she remembers thinking at boarding school that there was nothing particularly unique or special about her. And she had some struggles in her friendship groups. Again, no kind of major bullying or any kind of hugely significant incident. But she just had this feeling of feeling very homesick, feeling that there was nothing particularly special or unique about her, and having some difficulties in settling in with the friendship group. And she makes me think that there are a lot of young people actually who, in this day and age where to be the best is so important, when you're not the best, and let's face it, most of them are not going to be the best because only one person can be the best, it's really very difficult. You're kind of bland. Well, that's how they feel. So this next diagram is the kind of beginnings of a cognitive formulation of her eating disorder. So she has, as I mentioned, family history of depression. There were some issues in her parental relationship. Her father worked away for a long period of time. And she was slightly bullied, I think, by her older sibling. So she's beginning to kind of think about the fact that her core beliefs could be that she's unlikable and unnoticeable, and therefore feels worthless. So for her, this is the area that she's kind of most working on at the moment, and it's going to take some time to get to these core beliefs and dysfunctional assumptions. But for her, she's very, very clear that in order to be noticed or to feel special, she has to be the worst patient ever and the worst daughter ever, because that's the way people sit up and take notice. And through her illness, she's got to come home. She's got to have her parents with her all the time. And she's beginning to feel very special and noticed. So this is, in trying to think about it from a kind of cognitive point of view, this is the formulation that we're beginning to put together for her with boarding school and this whole idea about what is the point of me being quite a critical incident in her life, triggering and these core beliefs and the dysfunctional assumptions that she lives her life by. And of course, parental beliefs come into this. So the parental belief and expectation that you go to boarding school, for example, and that even if you're upset, you stay at boarding school. So that's kind of one way of thinking about a child with an eating disorder. But really, really importantly, and not on any of these diagrams, is what is going on to maintain this eating disorder. So we've talked about the contributory factors which lead to dietary restriction. And I'm sure many of us who've gone on a diet, you know what it's like at the beginning. You feel a bit more energetic. People notice that you look a little bit better. Your eyes are bright. You can think very clearly. You get a lot of positive comments from people. And that's what happens to these people. They get all of that initial kind of positive effect. And again, for most young people, girls particularly, they go on diets, but they kind of can't keep it going. So they probably last about 3 days, maybe 2 weeks at most, because they don't have that kind of temperament and personality that can keep things going. But for the young people we're talking about, this leads to extreme dieting. And then the negative responses come in. So these are neurobiological changes. They begin to deny things. They become more rigid and obsessional, increasingly preoccupied with food, and everything around them begins to change. So families become more concerned, maybe friends become more concerned, and they get to avoid perhaps some of the challenges in their life. So that maintenance cycle is an incredibly important cycle to understand when we think about how we treat young people with eating disorders. And we're informed by a study that was done in 1944 to 45 in Minnesota. And this was done after the Second World War, towards the end of the Second World War. And the reason for this study was because they wanted to investigate the impact of starvation to inform how they were going to refeed all these millions of people that had been in camps. Because they were aware of people being released from the camps and actually quite a lot of people dying because they would just start eating. And so this is the reason that they embarked on this research. And so this was an advert actually here, apparently for recruiting the subjects. And most of the subjects were conscientious objectors. So they were fit, healthy young men. And they... what happened to them is I think they were studied for about a 12-week period just to kind of get baseline data from them. Then they were placed on for 24 weeks on a diet of about 1,500 calories. So it wasn't absolutely terrible, but I guess for young men that was quite a little. And they were studied through the 24-week period, and then they went on to another period where they began to eat again, and they were put onto different kinds of refeeding diets after the dietary restriction period. So these are just a few photographs of them, and you can see that they actually became really, really emaciated. So this is them when they're being studied, being put through their paces. And interestingly, some of these, I wasn't at this conference, but many years ago, some of my colleagues were at an eating disorder conference and said that a couple of these men came to talk. And they talked about how unbelievably traumatizing this whole experience was. But this is a really, really important study because it tells us a lot about what happens when people starve. So the effect of starvation is that they have an increased preoccupation with food, as you can imagine. They spent a long time and a lot of thought went into planning meals. They changed the speed of their eating, so they ate very, very slowly, cut their food up into tiny, tiny pieces. Used lots of different condiments, salt, pepper, spices. And initially their hunger increased, but then it kind of reduced. The distress was very, very, very significant. They became very depressed, apathetic. I think one person started mutilating himself. Anxious, irritable. A couple were, I think, had to leave the study because they became so angry. They became violent. They neglected their personal hygiene. They became very withdrawn socially. They developed a sense of inadequacy. They lost their libido. They didn't have a sense of humor anymore. Became isolated. All their relationships were strained. And they were tired and weak and apathetic. And they experienced obvious physical changes, gastrointestinal discomfort, and a reduced need for sleep, dizziness, headache, hypersensitivity to noise and light, reduced strength, hair loss, edema, low body temperature, prickling in their hands and feet, and they couldn't concentrate anymore. Interestingly, they could do tasks, but they still couldn't concentrate that well, and their judgment was impaired. So I think what's interesting is how that, if you work with young people with anorexia, how many of those symptoms you actually see in the room with you. And I often give them a kind of list of all those symptoms and say, why don't you circle the ones that apply to you? And then say, well, do you know that those are the effects of starvation? And tell them all about that. So this gets me back to this cycle here and how really, really, really important it is to understand that whilst you might have all these contributory factors, this cycle of starvation almost kind of keeps this illness going. It's a really important factor in maintaining the illness. And to ignore it is problematic. And I do worry sometimes because I see lots of people that have kind of gone to various places and had a lot of work on all the factors that are contributing to their disorders. But actually, the maintenance cycle has never been addressed. So they're as starved as ever, and it really affects their thinking. At the same time, of course, these people are teenagers. And what's going on in a teenager's brain? Most teenagers, the brain is exploding. Yeah, it's growing, it's making all sorts of new connections. They're thinking about sleep and sex and friendships and sometimes school and various other things. But sadly, this isn't happening for our young people. And there's increasing kind of work done on the cognitive profiling and on the brains of these young people. I'm not going to focus on that today. But I think it's just important to think about that there's what they're kind of missing out on, really, because everything kind of stops. And just on a purely physical level, this is a picture of somebody with anorexia nervosa pre-refeeding, and this is after refeeding. And I think you can see the quite stark difference here. I mean, there's a lot of black in here, and the black is really fluid. So you can see here that there's a tremendous loss of brain matter that comes back when they've been refed. So purely on a structural basis, people lose a lot of brain matter. And this is my biggest argument when I'm trying to get them to eat fat. I'll show them this picture and I tell them, you know your brain's made of fat. And that's what's happening. So, as I said, there's a lot more kind of understanding about what's going on in these young people's brains. And what we don't know yet too much about is how much we're seeing that was there before they developed the illness. There is some evidence that there's some changes in the way their brains work before they develop the illness, and how much is there post kind of starvation, and particularly when people have been starved for a long time. So I think there's still a lot to learn there. But what I suppose there are some things that we know. We know that these young people have a kind of tremendous attention to detail. They can be quite rigid in their thinking. And one interesting thing that we know is that most of us, when we get presented with things like food or winning money or things like that, we experience pleasure. But interestingly, when people with anorexia get presented not just with food, with other experiences that most people without the illness would find pleasurable, they don't. And I haven't got the slide here. There was another study where people were, I'm trying to remember how it worked. It was really looking at dopamine release in the brain. And whereas the control group, I think it was in response to a meal or something, had a release of dopamine, and they experienced that as pleasure. Whereas the group with anorexia, the release of dopamine was experienced as extremely anxiety-provoking. So it was kind of like the same response, but the experience of it was very, very different. And that, as I say, is not just in relation to food, it's in relation to other pleasurable activities. So there's something different going on in those circuits and pathways that mean that our young people respond very, very differently to certain stimulations, which probably have a lot to do with how they develop their illness. So, I wanted 3 volunteers. Can I have 3 volunteers? Brilliant. I put these chairs here already.
Oh.
Because I just want to kind of have a think about what's happening in their experience of this illness. Yeah? So if you could, there we are. I'd like one of you to play a young person. So let's talk about Izzie. Yeah? Talked about her. Can you sit in the middle?
Sure. Oh,
Izzie.
me.
Are you Izzie?
Oh, I don't know.
Show me Izzie.
You be Izzie.
There you go, you be Izzie.
Okay, so want to be Izzie's dad?
Yeah.
Okay, now Izzie's about to face a meal, and you're going to refuse that meal. But it is a kind of life and death type of situation. You know, she's reached the point where everybody's getting really, really anxious about the fact that she hasn't been eating very much, and you're getting pretty desperate. Yeah? So you're desperate to get her to eat. Yeah? And I want you to play the role of Izzie's non-eating disorder mind. Yeah, so Izzie is 13, 14. She's going into year 10 next year. She's got a lot of homework on. She's got some difficulties with her friendship group. She's a bit worried about her sister and her mum. So these are the kind of things that are going on in Izzie's mind. Actually, could I have one more volunteer? Let's go. Yeah? You're going to stand behind her. Between us, we're going to play the role of anorexia.
Okay.
Yeah?
So I'm her non-ED.
So you're non-ED head. Yeah? So you're going to be talking about what non-ED stuff is going on in her mind, and we can be the ED stuff, yeah? But the situation is a meal, and you're trying to get her to eat. Yeah?
Yep.
She'll go for it, and we do it all at the same time. Yeah.
So do I have food in front of me?
You've got food in front of you. Here's the table. Here's the plate. There's your plate.
Hello, Izzie. Why are you not eating? Because remember, we went to the doctor, and doctor said you have to eat.
But I don't want to.
But if you don't eat,
You can't eat. You
get
can't eat.
unwell.
Leave me alone.
Don't do that. Don't eat that.
You know,
You're fat.
it's really unwell.
You're lazy. You're lazy. Everybody think we're lazy.
Doctor.
You'll be really fat. You can't do that. You know how terrible you'll feel afterwards. You'll feel just awful afterwards. You feel absolutely awful
What are you
afterwards.
going to do with your body?
Okay. That's what it's like for Izzie. And actually, the only way she can make it quiet is if she doesn't eat. Because if she does eat, the noise gets louder and louder. Yeah? Yeah. Thank you very much. You're not Izzie. You're not Dad.
I have a twin sister who is anorexia.
Oh, really? That must have been really difficult.
No, it actually wasn't. I haven't made done.
Where did I put my thing? No, there we are. You okay?
Yeah.
So that's what's happening in Izzie's mind. Let's just think about what's happening in the family. And a couple of journalists have written very eloquently about their experiences of having anorexia in the family. The one was written in The Guardian in February 2017, and she writes about, we watched on helplessly. We often had no idea what to say. I would rage between anger, can't you see what you're doing to yourself, pure frustration, for goodness sake just eat, and exhaustion, we're sick to death of this, you're so selfish. We became the world experts in saying the wrong thing. Family life was a war zone, and anorexia had a profound effect on the whole family. And Mark Austin had talked about this, I think, on television, and also wrote about it. What I failed to grasp was that she was seriously mentally ill and could not see a future for herself. I told her she was being ridiculous. I told her to get a grip on herself and grow up. And I even remember saying, if you really want to starve yourself to death, just get on with it. And at least once, exasperated and at a loss, I think I actually meant it. So I think that's really explains what it feels like to be a family member, and particularly a parent. So what happens in the family? Well, families, I guess, of any chronic illness accommodate to the needs of the illness. So the daily life becomes restructured around the illness. And I think, as I say, this could be about diabetes, it could be about leukemia, it could be about a whole host of other things. Decisions are delayed, so you can't really plan a holiday. You can't necessarily plan even where you're going to go at the weekend. There's complete disruption of family life and rituals. And all attention, there's a kind of imbalance in attention. So attention shifts towards that individual, and perhaps other things are ignored. And the family identity gets distorted. So there's quite a, thank you. So whereas a family may have been a family that did certain things at the weekend, where everybody went out to do their sporting activities, the family's identity gets completely changed. And the focus narrows to the here and now, the next meal. And as certain aspects of family function get amplified, so for example, if you're a family where mum tends to be the homemaker and dad tends to be at work, that often gets kind of magnified. So mum will be spending a lot more time taking responsibility for all the cooking and the feeding, and dad will spend a lot more time out at work. And the life cycle of the family, whereas normally at this age, teens would be going to secondary school, would be becoming more independent, would be engaging with their peers more, that gets halted and in fact actually reversed. So you find 13, 14, 15-year-old girls who are spending all their time at home. And as came across in those excerpts from the parents, there's a complete loss of agency and helplessness in families. So the illness becomes really central to how the family organizes themselves. So getting back to kind of our model of what kind of causes or what leads to an eating disorder, I guess when you look at that, you could see this way. Okay. You could kind of see how this could be, you could kind of intervene at all sorts of different levels here, really. You could try and help somebody with anxiety, with how to manage stress and puberty. You could think about kind of family patterns and what's happened in the family and what's gone wrong. And historically, really, a lot of work focused actually on working in the family, but in a very different way. So the first two descriptions of anorexia nervosa, Charles Laseg in 1873 described anorexia as intimately connected to the dynamics and conflicts in the patient's family. and recommended separating her from the family. And Sir William Gull, around the same year, said, "The treatment required is obviously that which is fitted for persons of unsound mind. The patients should be fed at regular intervals and surrounded by persons who would have moral control over them, relations and friends generally being the worst attendants." And actually, that's 1873, but I think that philosophy really stayed for a very long time. And certainly in this country, historically, the approach was very largely to hospitalize people. And this is kind of followed by Monition, who described the psychosomatic family. And he wrote about first, the child is physiologically vulnerable. Second, the child's family has 4 characteristics: enmeshment, overprotectiveness, rigidity, lack of conflict resolution. And third, the child plays an important role in the family's pattern of conflict avoidance, and this role is an important source of reinforcement for the symptoms. So that's in 1975. That's not too long ago. And I think there's still a kind of hangover of this, really. So that's where we were in thinking about how to treat young people with anorexia, thinking about family therapy in a very different way, and often using hospitalization. Until kind of it was kind of late 1980s. And there were a couple of studies that were done. One where patients, they were kind of aged between 14 and 50, I think. So it was a very broad range. And they, after a hospitalization where they were weight restored, they were then randomized. This was at the Maudsley. They were randomized to individual and family therapies. And this is probably one of the most important studies to inform what we do today. And what they found was that adolescents who'd had an illness of less than 3 years did better in the family therapy group. So things had developed. So whilst one could intervene at all these different levels, today the kind of primary intervention initially is through the family on the maintaining factors. And kind of family therapy for anorexia nervosa, or family-based treatment, as it's been coined in Stanford, was born. And there are a few principles to family-based treatment. The first is that no assumptions are made about the illness, so about the cause of the illness. So there isn't and parents often come and they really want you to, what did we do wrong? They want the answer. If you have the answer to what caused the illness, then surely we can treat the cause and then things can get better. So number one principle in family-based treatment for anorexia nervosa is you don't make an assumption about the cause of the illness. In fact, the cause of the illness is really not really talked about that much. So I guess at our assessments we might talk a lot about what's happened in that young person's life to understand the kind of factors that are at play in her life, but not about these factors as being a cause. The second thing is to identify what needs to be done to move forward. So not looking at the past, look at the future. The third principle is the principle of externalizing the illness. The child, and the way of thinking about it is that the child doesn't have control over the illness. They didn't choose to develop this illness. And that's kind of got a curious effect. Most of the young people I work with, they don't like this too much, certainly at a particular stage. They get really annoyed when people say, it's your anorexia talking. They hate that. They hate to think of it, because for them, the experience is that they are that. Yeah, so they really, really struggle with this externalizing. But I think it's a useful way of thinking about it, particularly for parents. And it certainly works to reduce parental criticism. the therapist takes a non-authoritative stance and is seen as more of an expert consultant. So parents are really seen as the experts in their family, which is pretty hard for them when they come along and feel like they're useless. So the aim is really to empower parents and to see parents as the best resource for the family. And the whole principle is that parents are really in charge of that child's recovery. And I think this is where this kind of model of treatment, I think, is slightly different from anything else. And I work on an inpatient unit as well. And what I find is if we bring young people who seem to be developing personality disorders into the eating disorder unit, where the stance is very much about the child not being in charge of the illness, the adults are in charge, and we bring somebody else with slightly different diagnosis in, it just doesn't work at all, because that model of taking over responsibility for eating and other things doesn't seem to apply very well when you're dealing with even adolescents with other disorders. So I think in young adolescent eating disorder treatment, this is a kind of slightly different stance from what you get in anything else. And the initial focus is on symptom reduction. So reversing starvation and addressing the maintenance factor. So that whole cycle we talked about. Yeah.
When you try to empower the parent, will this be contaminated by assuming that they as a cause of illness?
I suppose the hypothesis is that the parent's loss of power is not seen as a cause. It's really seen as perhaps a consequence of the illness, actually. So I think you're kind of empowering them to kind of discover their agency and their authority again, because most times the parents are so eroded and their confidence has been eroded. I mean, because I think one of the most fundamental things of any parent is to keep their child safe and to feed them. And when you aren't able to do that, I think it really erodes your confidence as a parent. So I don't think we kind of frame it in terms of the loss of power being a cause, rather it's as a kind of consequence of the illness.
What would be the answer if they ask? How is the cause?
I would probably always say the causes of anorexia are, there are so many factors that go into developing an eating disorder that there's no kind of one cause, and I think actually it's not really useful to kind of go searching for what the cause is. What we have is a situation now, and we really need to move forward and think about what we have to do now.
What kind of age is there kind of ceiling of age that
It's interesting you asked that. I mean, generally, this is a model for adolescents. I don't know the outcomes, but I kind of, one of the papers I was reading recently talked about it being used in adults. I think there's only kind of one study to do with that. So generally, this approach is in adolescents. I think if you kind of think about the effects of starvation and how people really quite regress, actually, as a result of being starved, this kind of model is probably quite appropriate even for older adolescents. However, I will say my adult colleagues do say that you create a real headache for us when they come over to adult psychiatric services, because they kind of come over and they're utterly dependent on their parents. So I think partly that's when the treatments got stuck, actually. It can be, I find it a little bit difficult when people are in a more kind of autonomous age, except they're not behaving responsibly about their lives. So I suppose you could argue it that way.
You talked about in our subject today about the cause of the illness. I wonder, do you look at it in terms of addiction? So when I think about alcohol, drugs, etc., food, I think of it in terms of an obsessive compulsive behaviour. Do you look at addiction? Do you look at anorexia as an obsessive compulsive behaviour?
Yes, but in a
There's
different.
definitely lots of elements.
There
in
definitely
there
overlaps,
that
aren't there?
cross over with
Um,
drugs now, and compulsive overeating. is
yeah,
Another
yeah.
Do anorexics tend to become alcoholics?
Not necessarily, no.
I do.
No, I mean, I think there's a small group. So I guess there's a small group of, subgroup of people with anorexia who have binge purge anorexia and may also have alcohol problems. I mean, and those are the people with the kind of the most difficult illnesses to treat, really. I mean, I'm not seeing them because I see younger people, so they haven't kind of.
And I see people who've come into Overeaters Anonymous, if you like, as a 12-step fellowship, that have come through different fellowships and have realised that actually they see their first addiction was food.
We don't view it as an addiction
Okay.
at all. I suppose you could argument that there are kind of elements of exercise that are addictive if they're engaging in exercise behavior. I suppose, we have a kind of the starvation model, as I've been talking about, which I suppose we don't kind of view it through an addictions
It's
kind of
obsessive,
prism.
isn't it? It is obsessive and compulsive.
It is, but I suppose it's so related to the kind of physiological state of starvation.
Maybe there's a sort of kind of a dropping off point, if you like, that when you get so far into it that actually it gets more of a different type of mental health issue.
Yeah, I think possibly. I suppose some of the people do talk about not so kind of. I suppose the kind of overlap is where you use a behaviour to manage a feeling.
Yes.
Yeah. So I think for lots of these young people, the feeling that they're managing by starving, because starvation just takes away emotion, so you're kind of numb. So, part of what we talk about as their weight goes up is that you start feeling again, and that's kind of going to be very uncomfortable. Yeah, so I think there's an overlap there.
Sorry, like can be the like how neurotransmitters saying you talked about dopamine, serotonin plays a like important role because there's receptors in the gut. So like what we eat
Yeah.
goes like how we feel.
I think so. So I think starvation kind of makes everything shut down really, and then it always begins to kind of rev up again, and the experience that is quite overwhelming.
Sorry to interrupt. Something with my experience with my daughter was she got some very early signs of magical thinking. Have you ever seen that in young children as a precursor to them the anorexia? Then she had some compulsive disorders. I remember Andrea Key, who we went on there, said, I said, Christ, what is that going to be next? I said, this is the end of the road. You get these things and these. Have you found that?
Yeah, I mean, a lot of kids I see also have had brief spells of more OCD type of behavior when they're kind of 7, 8,
Yeah.
that kind of age. Yeah,
And then
yeah.
this is the end of the road.
Most of the time.
One
Yes.
That's the end of it.
Meaning, I said to her, what else am I going to get? After this, anorexia, will there be alcoholism?
I think a lot of people, though, do continue to be rather anxious
Yeah.
and have a kind of might have a kind of anxiety disorder and kind of under that umbrella. Yeah. So if you look at the kind of longer term outcomes of anxiety in people with anorexia, quite a high proportion of them continue to have anxiety disorders.
And there was talk about the DSM-5 at one stage putting OCD as part of the addiction process because of the crossover with the obsessive, the obsession and
Yeah.
compulsion.
Yeah.
Would you say that sort of hangover of anorexia is also quite rigid thinking, like quite black and white thinking? Even
Now that's an interesting point, and this comes back to the point about we don't know what was there beforehand.
right.
So it may be that, and there seem to be different groups of people. So there's one group that it doesn't kind of long term display that kind of more rigid obsessional perfectionist thinking, but there's certainly other groups that do. So we don't know whether some of that's a kind of impact of chronic starvation. And of course, a percentage of people do stay very unwell forever. a small percentage, but nevertheless they're there, or whether it was there beforehand, and that's just the way their kind of brain has been developing. Because you kind of need to remember that these illnesses start when the adolescent brain is developing. So it could be that there's something about that brain development that either has been stunted, or it's the fact that the brain has developed and that kind of that kind of way of thinking is manifested, because that's the way their brain developed. Yeah. Yeah.
When you think about it, in
Yeah.
terms of that, the puberty.
It does. And at that time,
Estrogel, definitely the anxiety.
yeah. And at that time, we know that the brain is kind of mushrooming,
Yeah.
and all sorts of and hormones obviously have a part to play in that. So I think there's a lot we just don't know yet, but certainly the rigidity in the rigid thinking can stay in a certain proportion of people.
Do you find any kind of trend in terms of culture or I know you say you don't look at the why, but you must do some sort of assessment or thing. Do you find any trend in terms of people's background, their culture, their religion, or their home life, or anything like that?
It's hard to say, because I think there are probably lots of people we don't get to see, and that maybe the culture plays a part in that, where they maybe don't consult doctors, or actually, because of the kind of culture they come from, there's an assumption made that they don't have an eating disorder. So I think it's a lot of people feel, a lot of physicians feel that if you come from, there's a kind of certain type of patient that has an eating disorder, and actually if you don't belong to that type, then you don't have it. So I think it's hard to say, really. And I think it's different depending on the eating disorders. So, we know things like bulimia, for example, is very much more present in urban populations. In urban populations, yeah. So I think that's perhaps a bit more sensitive to cultural influences than anorexia nervosa. What am I doing?
Do you think that the rejection of food could bring a rejection of the physical body and possibly as or that was something spiritual, sort of kind of like as well as that program?
Is the rejection of the physical body a rejection of the body and a search for something spiritual? That's an interesting question. I think when they look at anorexia in different cultures, coming back to your question about culture, sometimes the illness is there, but it's in a kind of different format. So it's not because people are wanting to lose weight or diet because of appearance, but perhaps for other reasons. And certainly there is a kind of, I'm just thinking, going back historically, there's a hypothesis that perhaps, many hundreds of years ago, there were descriptions of people that sounded as though they had anorexia. Thinking about the description I read to you from 1705, where they actually, it kind of manifested through religious practice. Yeah. So I think young people don't think very much about spiritual things these days, and maybe that's something else one could think about. I do think when you look at recovery, that finding things that are more fulfilling, whatever those things are, is certainly one of the key factors. Yeah.
I noticed with her, I thought it was to stop her becoming an adult a part of it. She was scared of boobs coming or getting pregnant. It was a big scare, sitting on a loo that somebody had been on, that magical thing. So I wondered if part of that, and if you noticed with 30, 40-year-olds, is it the scare of growing up? The porn they might have seen on, and a scare of that. Is that something that, that's come into play at all?
I do think so.
She was trying to hold back time slightly.
Yeah, and I think it's maybe not even about porn and anything quite as extreme as that. I think it's just the task of growing up, perhaps even particularly these days, is so challenging. So, facing the challenges of secondary school, we're not going to talk about social media too much, but that brings its own challenge all of its own. Friendship challenges, your body changing, things in your family probably changing at the same time. I think there are so many challenges that are perhaps feel quite make people feel slightly out of control anyway. So I think there's enough there for many youngsters to feel anxious, and in this small group then to kind of use anorexia or eating as a way of managing that. Yeah. Yeah. It's not, I don't know that there's so much they don't want it, but they just don't know how to ask for it, and because they don't want to be a bother. And they just don't know how to express that need, because they should be fine, because they go to a nice school and they've got nice friends and they've, why do they have a problem? Yeah. Mm. Mm. But it's interesting, you've touched on something that I think is also important, is that certainly a kind of 13, 14, 15-year-old age and stage of development. And I think it comes back to this kind of intolerance of imperfection. Kids are at very different stages. So you kind of see them walking, and their height differences are enormous, and their weight differences are enormous. And so that feels really intolerable for girls perhaps who have developed at an earlier age, or who are slightly plumper than their peers, and for boys who are not as tall and not as well developed as their peers. So there's that variation, and I think most of my patients, I almost wish I could wave a wand and they could be 18 and have got there, and things have kind of evened out a little bit, because there's that variation in body, and there's kind of friendship fracas that seem to happen constantly for a few years that really throw these young people. So yes, they may be distorted, but I think they're distorted also in their perception of what's normal.
But then that's always been the case, in the sense that there's always been taller,
Yes.
there's always been shorter, there's always been wider. I wanted to pick up on the element of control, in terms of someone was talking about them attention seeking and then not wanting it or not knowing how to handle it. And what about the control element with all of that? Because my experience of people in my family and people I know where one of the children are anorexic is that they do consciously or unconsciously control what's going on around them.
Mm-hmm.
So what is that about?
I think it is about that. Kind of making the world a safe place.
Okay, so it's because you think they feel unsafe,
Yes.
the way to feel safe is to control
Yes.
what's going on.
You know the noise we heard there?
Yeah.
It's quietening the noise.
Fanatic in the end.
Yeah. So, okay.
While implementing these points, how to control for quieting the noise?
We'll go on to that.
Yeah, okay.
So, this is the model of family therapy that has been developed at the Maudsley and at Stanford, and also in Australia. And this is also recommended in the NICE guidelines. And it's described as having 3 phases. And there are slight differences between what's practiced at the Maudsley and what's practiced in the States. But essentially, quite a lot is the same. And what is interesting about it is the professors in Stanford have actually manualized this as well. So it's people across the world are being trained in this model of family therapy. And what's important about it is not generic family therapy at all. So the focus in phase 1 is on a rapid restoration of physical health, where the parents are in charge. And when I started learning about this, I thought this felt like it was wrong. Because here these kids are wanting to be are struggling with feeling out of control, and actually what you're doing is you're bringing somebody else in to be in charge. And I also thought, well, these kids are struggling with their identity and struggling with the whole idea of autonomy. How can you then put their parents in such complete charge? And I remember I was a kind of junior doctor at the time, and Ivan Eisler saying, but actually there is no choice in life about eating. They can't make a choice about that. And so that is the approach here, really. So I guess there is a choice if you want to die, but still. So phase 1 is focusing on restoring physical health. Again, this is where it's different. The weighing of the patient doesn't happen by some nurse or doctor somewhere else. The therapist weighs the patient at the beginning of the session. And a lot of these things have been very uncomfortable for people. And the session is focused on what's happened in that weight. How did you get this, how did you manage to do that this week? What went well, what worked, what didn't go so well, all focused on weight gain, weight restoration, and using the word restoration as opposed to gain. I think there's a subtle difference there. So you're restoring their weight, you're not gaining their weight. The parents have to make the decisions about eating. And the real aim is to help young people to recover in their day-to-day environment. As I mentioned to you, historically people were being admitted. They were being admitted for well over 6 months. And there was another study done by Simon Gowes which demonstrated that admission really actually didn't do anything advantageous compared to the outpatient treatment. And if anything, it created a whole lot of problems. And if anything, it kind of made people's prognosis worse. So there's always been a lot of concern about how many young people are being admitted for lengthy periods of time inappropriately. Siblings are really given more of a supportive role in this model. So the parents are in charge. I mean, there's not an expectation that the siblings are in charge or the siblings play a part in making sure their sister or brother eat. One of the things that's also a little bit controversial is the family meal session. So in the Maudsley model, they don't have a family meal session, but in Stanford they do. And the aim of the family meal session, they don't bring in a full-on three-course meal. They bring in a snack or something. And the aim is really to coach the parents in how to help their child have just one bite more than they were aiming to do in the first place. So, and this phase 1 really, it can carry on for a long time. It carries continuous steady weight gain and the child is less resistant. And the thinking is that a lot of the difficulties that these kids are manifesting actually may go just with reversing starvation. And for many of them they do, and it's quite extraordinary. So when I see people who are unbelievably anxious and they have some OCD symptoms and their mood is terrible, I never know whether actually that person is going to be better when their brain is better nourished or not. It's really difficult to tell. So that's why the phase 1 is really focused on restoring their weight and their nutritional health. And it's all focused on kind of thinking forward and not really going backwards. Now, of course, those people who kind of work with families will know that the way parents do things is informed by their history. Yeah. So you kind of come across problems like a mum or dad who had a kind of abusive family background, and they feel that they, whatever else they wanted for their children, they were not going to be the same. And almost invariably, this kind of situation really generates feelings of rage, frustration. And so you can imagine a parent sitting there thinking, but I don't want to be like my father in insisting and being forceful and insisting that my child eat. So it can bring up a lot of dilemmas for people depending on their backgrounds and their own kind of families of origin. So I guess that's where thinking about what's gone on in parents' life may inform how they then carry out this task of feeding their child. But a lot of the discussion we have is also very, very practical. It's about planning meals. So you asked about quietening the noise. The kind of things that help with quietening are planning, things being predictable, learning that if your grandmother's coming around for the day, she's going to say unhelpful things, how to think about how to help your child with the unhelpful things that she might be saying, perhaps how to speak to the grandmother beforehand to just zip it up. You might, some families or some young people find it useful if they know what they're going to have for 3 days in advance, so there's kind of perhaps menu planning with them. They don't have a choice, or they may be sometimes given a choice of 1 out of 2 things, but the parent is largely deciding. So there's a variety of things that can help people feel just a little bit calmer. What throws them is unpredictability, even unpredictability to the extent of the shop ran out of Hovis bread and so they got Warburton bread instead. Yeah? That can be very difficult. Now clearly there's a kind of real life does intervene, and they've got to learn to be tolerant of a degree of inconsistency. But planning, consistency, and predictability are the kind of things that will really kind of help dampen down some of that noise. I'll come back to the noise. So you'd spend a lot of time in this phase 1 of the sessions working on that kind of practical stuff.
I was wondering about the parents being in charge from the place of how are they evaluated for their parenting style or how they are with food? I've worked with
That's a difficult one.
where there might be eating disorders going on with the parents more often than
That's a difficult one.
I also have cases where they're even more extreme, where there's actually incest with the father and you never see it, and then the parents are in charge.
I think this is where obviously you have to have had a good assessment to begin with.
Right.
Yeah, so I think if you have concerns about parenting, then you may not be taking this approach. There are also different models of this where, for example, if there's a kind of really high levels of conflict and criticism in a family, you might do what we call separated family therapy, so where the young person is seen separately to the parents.
Right.
And I sometimes actually mix and match it anyway. So if I kind of have a sense that this is getting a bit heated and what's happening here is not helpful for this kid, I might ask them to go out for a bit and then see the parents on their own and really kind of talk them through why they're responding in that way and what's driving, they may have a very good rational reason for doing so, and to kind of really tease it out and to think about what's the best response.
So is there an evaluation of the parents or an assessment?
So when we assess people, certainly when I first see people, I take 2 hours for my initial assessment, and part of that is seeing the family as a whole, and you're kind of obviously watching all the interactions, and I would see the young person on their own, and then I would see the parents on their own. And actually sometimes that in itself gives me the first start, but it's not necessarily the whole thing. But you're also up against the clock often because these kids are starving, so.
So how often in your experience when you're seeing these adolescents are you noticing there might be a parent problem with the parents being in charge, that is?
I think I probably notice it more the other way around, actually, where they're struggling to be in charge.
Okay.
It's certainly there. And as I mentioned earlier, I work in an inpatient setting as well. So I would say a lot of those young people, they have much more, their problems are more complex, and probably the family issues are more complex there.
Okay.
So we might be a little bit more judicious about how we approach this. But I worked with a family where the young boy, actually, where the mother had an eating disorder. But I guess what was fortunate is that she acknowledged that she had one. And we did it, most of the sessions were separated. And we spent a lot of time on with the boy about what he needed, understanding that his mum had an eating disorder, what he would need from her in order to eat at home. And eventually she went into her own treatment. I guess, so in that situation we were fortunate because she actually had some insight into her illness. I guess where if you had somebody who didn't, and it was really apparent that it was interfering in the care of this child, then you would be going down, other kind of statutory routes to think about how this child was best managed.
Okay.
Yeah.
I'm really aware that something like child sexual abuse is something that often, even if you're working with someone for a while, it doesn't come out until much further down the line.
Yeah.
And I'm not sure what your experience of that is working with anorexics in terms of, is there any correlation, or do you see that as something that's happened
No.
with the families that you've worked
No.
with? Is that part of the story?
I wouldn't say there's a kind of higher incidence than, in fact there isn't if you look at the evidence. Yeah. I just want to carry on.
Sorry, I missed. Who do you see first in the family? Do you see the whole family?
It depends on the age of the patient. So I would, if they're kind of an older teen, I would ask them what they wanted, whether they want to see me first or with their parents. Very often they want to come in with their parents. You need to remember they're kind of quite young and immature often anyway, and very anxious themselves. So, but I do give them that choice. When they're 13, unless they specifically say they don't want to, then I see them with their parents. So it kind of slightly depends on the age. But at some point we get them all together. Phase 2 is when you start, sometimes I think I've spent forever on this phase. You give back responsibility for eating to the adolescent. So then there's been lots of discussions about when they start eating at school and how will the parents know they've eaten at school, and do they take a photograph of their meal and text it to their parent, all these kind of things. And then phase 3 is where you're getting back on track with what you should be doing at that stage of your child's life. And thinking about the things that made them veer off track in the first place and how to help them with that. So the things that they might have been anxious about, the friendship difficulties that they might have been having. And of course, a lot of this is perhaps changed by this, because you might be 1 year down the line now, and they've grown up a little bit too. So those are the 3 different phases of this family therapy model. And I think there is a kind of worry that people get stuck on that phase, but you do need to kind of move them on to the next phase. And it seems to happen almost fairly naturally. I'm going to skip over that.
What's the length of those 3 phases?
Well, interestingly, if you look at the evidence, they have done studies there's one study looking at the different lengths, and where they compared a 10 session intervention to a 20 session intervention. So generally the thinking is it's about 20 sessions. Certainly at the Maudsley, they see young people over a year. And what they found in that comparison between 10 and 20 sessions is that actually the outcomes were fairly similar, which surprised me, I must say. But where those parents, I think it was where parents were on their own, where single parent, lone parents, or where there were more obsessional characteristics, they did better with the 20-week sessions. So it can be fairly limited, but there's obviously still going to be a group of young people who need more intervention after that.
Certainly the books I read suggested that the children who had a focus, who had hope,
Yes.
something to think about other than the food, tended to recover a lot quicker and better than the ones who didn't.
And the difficulty there is the longer you're in the illness,
Yeah.
the longer you're starved, the more entrenched it becomes, which is why it's so important to get on top of that starvation. And
She needed film calls to go to something
yes,
to get better at that. That was
yeah,
everything.
yeah. So some people need something a little bit more intensive, and this is where something called multifamily group treatment's been developed. So I know it's been used in addictions, historically in I think the Castle Hospital in schizophrenia, they brought family groups together, and also in conduct disorders. And it's the same principles as family-based treatment that I've described. So you get 4 to 6 families together. There's an introductory session where they meet the family, and then you have a 4-day intensive workshop with the family, with all the families. And it's kind of various groups, whole groups, separated parents, fathers groups, mothers groups, siblings groups, patient groups, altogether groups, go off in your separate families, any combination. And the benefits really are kind of bringing the expertise from a whole number of people. And it becomes much more family focused than doctor, patient, therapist, family focused, if that makes sense. So it's very useful this if you've got a bit stuck with a family and you kind of get to feel that you're not very good for them and maybe they're not so good for you either. So it's really useful to bring in the momentum and energy of a whole lot of people struggling with the same thing under one roof. And you get the perspectives of different of people from different families. And it's much, you know, a parent can tell another parent, I saw you kind of do this or that in a way that the therapist really can't. So parents can challenge each other more as well. And it is really the same principles of the multifamily group, of the family therapy I've described. So a typical day is, day one, you'd start all together. You've had the introductory evening where you've met a family who's been through this process. And you have a group where everybody introduces themselves and says a little bit about themselves. The day is predicated around the meals, so morning snack. And then the parents have a group planning lunch, whilst the young people go off and do some kind of creative exercise. And the lunch is done all together and observed and supported by staff. And it is really hard, let me just say. It's really, really hard. It's one of the kind of hardest things I've ever done. Because you're trying to kind of, everybody feels scrutinized, I guess, and you're trying to support these parents to do something that they have found extremely difficult. Kids run out, food gets flung around, you know, it's a very tense, and also these people don't know each other. So, but gradually over the days, the parents as a group develop a few more strengths and resources and learn from other parents about perhaps how to tackle those difficult situations. Then you have feedback, snack, and then the young people might do a reflection on their portrayals of anorexia. So that's an example. But there are lots and lots and lots of different exercises that we do. So we do a lot of externalizing. So that exercise we did at the beginning, where we did the noise and somebody playing anorexia, so we would do that kind of thing. We would do family trees, so each family would go off and make a family tree. And the reason for that is to bring out the idea and the story that actually every family is different. There's no such thing as a typically anorexic family, and every family has its strengths. So as a therapist, you're kind of drawing from the family trees and looking at the strengths that are evident in this family and bringing out the differences between the families. There's a lot of artwork that's done in the siblings groups and the young people's groups. And you might do other things. So there's a lot of role play. So the young people play their parents, and the parents watch them playing them and learn quite a lot about what they're actually saying to their children that they don't realize they're saying. There's a kind of exercise where you all create a meal out of pictures of food, and then the young people try and feed their parents. You might have an exercise where eventually when the families know each other really well, they swap children for lunch. And that is very powerful actually, because you either think, I think as a parent, wow, I'm glad this isn't my daughter. Or you think, actually I can do this. And where I trained in this in Dresden, and actually they video the families, and then they watch the films back, and they can then see, you know, parents in a kind of, well, all of us, I think, in a group situation like that, you don't want to create a scene, perhaps, so you don't insist on that food, or you can see that it's been dropped and you don't want to say anything. but they pick it up, and the other parents kind of challenge each other about what they're doing. So it's very, very powerful and very tiring as well. And towards the end, you kind of help them all develop a toolkit for survival. So that's multifamily groups. And the model that was initially created, we have the 4 intensive days, and then we have some follow-up days over the course of about 9 months. So I'm going to stop there for a second and see if there are any other questions, because I think time is kind of running out.
Sorry, I have a question that's sort of more to how anorexia or eating disorder in general can sort of start. Because I find often, of course not always, but often it starts by actually parents or within the family, things are being said, being done. Again, that's, it's sort of not once, I understand once, anorexia has been, has developed, you don't go back and look for the causes. But what I'm trying to sort of get at here is how to stop it from developing. So, for example, I know that a lot of children when they are, 12, 13, 14, whatever, they're a bit chubby, let's say, definitely not overweight, but, borderline, let's say, And parents often say to like, don't eat so quick, don't eat so much, don't eat so this, even when they're healthy. So, and I know for parents it's very, very tricky to find, a line of how to do it. Because on one hand, you want your child not to become, not to cross that line of chubbiness and become overweight. On the other hand, you don't want to make it into such a,
It is so difficult.
So what is the way to do it?
Particularly because I don't know what happens in other countries. We have this program where children are weighed at certain years, and then as a parent you get a letter saying your child is overweight. Wow. I had that letter. It looked perfectly normal to me. Yes.
Oh, okay.
And so the anti-obesity message is so strong.
What country is that?
This country. Yeah. So children are weighed in, I think, reception or year 1. I haven't had a letter since, so I don't know when next they're weighed. But and I think there's some research that shows that if children are a particular weight at that time in their lives, then it kind of predicts obesity later on. And
it's at the age of 12, 13, when
it's very difficult.
So, is the advice to just, let
I
them
think
get on with it until they're
no, I think the advice is to encourage eating that is healthy.
No,
that's
it.
Granted.
Let's
Yeah, eating that is
these are all
healthy
families-
and healthy exercise.
What I'm talking about is all families that are sort of, the picture, whatever, perfect families, all is good. But, you sit at the table and because it comes up quite often, I hear that quite often, and you see at that moment, you say, because for some parents, it's very hard to control it later on, but for some it's the opposite, it's very hard to not say. So,
I think one has to be very careful about how you phrase
so
it,
this is what I'm saying.
which
When-
is why I
what's the
say
balance?
I think the balance should be more on encouraging the health
Yes.
and wellness than discouraging being fat.
So don't focus on the food.
Don't
just focus
or
on
focus on
what you
eating
need to be
healthily.
healthy. You need
Yes,
to be healthy
Not-
generally, and this is how you are.
not focusing too much on the fat. But it's very difficult.
Not the fact, but the whole eating, I don't know, sit straight, hold, because there's a lot of thing at that age where, when they're very little and you try and teach them eating with their food, then there comes a point when they're very proud and they do it very properly, and then at 12, 13 they get it, it's sort of,
Yes, I know.
They slouch or they eat fast or they don't sit properly, or, those kind of, instructions during the mealtime, let's say. How much instruction,
I think I don't know. And I guess every family is different. And I really don't know how much that has a part to play in developing an eating disorder. Hard to know.
I want to ask a really brief question.
Yeah.
Do you see more boys now, or is there more of a prevalence of male eating disorders as much as say?
I think there's an increasing prevalence of male eating disorders. Yeah, I do.
And do you treat them slightly differently or exactly the same?
The difference with them is that they present slightly differently. So for boys, often the problem is less about body weight and more about leanness. So they're wanting to be ripped. And That's what it's about. So so there's often more of a problem with exercise and compulsive exercise and dietary restriction, but it's the exercise which is really, really, really difficult to treat. It's very difficult, and it does become very kind of compulsive. So it's a kind of different presentation, but kind of same worries, I suppose. Yeah.
I notice that it's not an addiction, and I know it's treated differently with children, isn't it? But in an adult community, there is that class of model eating disorders, and a lot of recovering people have had eating disorders. So I wonder, is it this group's because they're intervened on, they then don't go on and
Well, yeah, I think so. And I mean, I suppose we just don't conceptualize it in that way. We just don't conceptualize it as a kind of addiction. And what we know from the evidence of family therapy, which is now the kind of first line treatment, is that the majority of young people, so for most of the studies, between about 60 and 90% of people go on to, at 5-year follow-up, have a good or intermediate outcome. A high number of people still continue to have anxiety. Not necessarily other addictions, but anxiety. And a small number, I mean, again, the studies vary, up to about 30% do go on, think about OA, to develop a more compulsive eating and binge eating. So there is a proportion that do go on to develop binge eating.
60 to 90% is a big gap.
Yeah, so I would say probably about 60% of those is a good outcome, and the remainder is an intermediate outcome. And then there's perhaps 10 to 20% that remain very unwell.
Yeah, I run
This one.
I work in a small drug clinic, and we found out that a few of the addicts had a primary eating disorder. That was
Yeah.
their primary problem. So we were finding with the 12-step model, we were finding treating the addictions, but not so good with the eating disorder.
I think there are things about the nutritional and the physiological side of it that you can't, you have to deal with. And I also think things about body image that you have to deal with very specifically. And I remember when I worked with adults, I remember there were patients there who used heroin, for example, to lose weight.
Yeah.
So the prime motivation for their drug use was, as you say, to kind of feed their eating disorder.
They were using drugs to, in our case, to cope with their guilt about the eating disorder.
Interesting.
Also,
Interesting.
I think it's different between compulsive overeating and anorexia. They're different
Yeah, I agree.
manifestations.
I agree.
So we were talking about the 12-step, but one of the perhaps benefits, I suppose, is a sort of ongoing support community for a period of time. Is there something similar or equivalent in the context of somebody who's recovering from anorexia, or is it just...
Well, there are various forums, so not generally within the traditional treatment regimes, but there are organizations such as BEAT who provide telephone helplines, online forums, people called young ambassadors who are recovered and who kind of trained up to go and give support. So there's that organization, and there's another organization called FEAST, which is, I can never remember what it's, I'm not going to go into that, which is a family, families empowered and supporting treatment of eating disorders. So that's again another online forum for families specifically, and that's a kind of international forum. And I went to a presentation from them recently, and a number of parents have found that incredibly helpful. So there's in those contexts, BEAT used to run quite a lot of local support groups. A lot of those have fallen away at the moment. So I think there's space for that, actually.
There is another
You have
specific
talked about
12-step
medication
program.
with anorexia.
Yeah.
Is that not something you tend to prescribe?
There's not a lot of evidence for it. I mean, I was primarily talking about family work here. I use it sometimes.
Just because sertraline proved to be quite useful for quieting that voice.
Yes, I mean, to be frank, there's a point at which one can try anything. So I do sometimes use sertraline or fluoxetine. And again, in adolescence, there's not a lot of evidence for any of this. So I might use fluoxetine or sertraline or some other medications. But I think the point is, actually, until somebody's at a reasonable weight, you honestly don't know what you're left with.
And just one other thing, I wish that I'd been given, you say all the recovery is done at home, but so little support is given to the family on how to sit with the child when they're struggling with eating. And sometimes a cushion over the leg, I was told we read about, is used position of constantly checking, distracting them after the meal, making, you know, that half hour after making. These were all tips nobody gave me, and yet we were throwing the child, oh, you've got to deal with it.
I mean, that's part of what this phoneme-based treatment should be doing in that phase 1, is really thinking through. And the difficulty is your family is your family. So it's not about me coming along as some expert saying, this is what you should do. But sometimes I say, well, you know, I've known other people to try this. The distraction, we spend hours thinking about what kind of things might distract. So that is the aim of that phase, really, is to look at. Exactly. Anything else?
Is it helpful challenging sort of adolescents who are choosing not to eat in that kind of structure of the sort of first phase where it is?
Well, I was going to do an exercise which we didn't get onto. This whole question of the family meal and whether you actually do it within the therapy, because we don't really know which bits of the therapy work, but we know that there is good evidence for it. And one of the things they've looked at is the family meal and what is actually useful in that meal. And you probably know about it in working for addictions. You know, bullying somebody out of their addictions is not going to work, is it? And it's much the same here, but you know, these kids are going to die if you don't do something. So you can imagine parents get more and more and more hysterical as the meal goes on. And what the one study showed was that being kind of repeated entreaties to eat this food didn't work, was actually negative. But the other study showed that repeated requests to eat the food was positive. And the conclusion drawn from these two was actually probably, and in my experience I think this is what works better, and other people might have better ideas actually, is where something is delivered in a very kind of warm but firm way, and in a relatively unemotional way, so not with anger, not with tears, not with pleading, but where it is persistent and relentless. And I was thinking about that voice, and perhaps you have to find a way of having your kind of persistent, relentless voice come through that noise. It's very, very exhausting though, because you're doing it 3, 4, 5 times a day. But that's all the nurses are doing on the wards, really, face it, is really being persistent and calm and relentless. And it reminds me a little bit of, do you ever watch Super Nanny? And Super Nanny, when she's dealing with these kids who are really behaving in a very out of control way, she kind of leans down and she gets the parents to drop their voice and to look at the child and to say the same thing over and over again in quite a low, repeated tone. And it seems to help the child. And I often think about that when I think about how you get a young person to eat. There really is no magic answer. It is a matter of persistence as well. I'm not sure Alexa has authority, that's the only thing. And as you mentioned, looking forward to things. So having distractions on the table, having your kind of wish lists on the table, those kind of things.
Yeah, like the food is your medicine.
Yeah, so these mantras. On the slides there are some references there, and there's also reference to kind of other models of carers groups for people which have also been developed at the Moores, for people with kind of more long-term chronic illnesses, but we didn't have time to get into those. Okay.
Thank you very much.